Good afternoon, everyone. Welcome to the NC HealthConnex quarterly Teletown Hall webinar. My name is Garrett Smith. I'm the Business Relations Manager here at the North Carolina Health Information Exchange Authority. Today's meeting, just FYI, will be recorded and made available on our website once this meeting has concluded. The presentation slide deck will also be sent to those that have been registered for the meeting. If you do have questions during the meeting, please place them in the Q&A box in the WebEx meeting. And just going to go through an overview of what we're going to be discussing today. So during today's meeting, I'll provide a quick update from the NC on some recent updates. The team at NC Medicaid will give an overview of Taylor Care Management. The NC team will give an overview of the HIEA and NC HealthConnex and NC Notify and how those two services can help support Taylor Care Management. We'll then wrap up with some recent questions and review any of the questions that came in the QA box. So just to go through some introductions of who you'll be hearing from today, who will be involved in this meeting. From North Carolina Medicaid, we have Kelly Crosby, Chief Quality Officer, Lowell Alvarez, the Associate Director of Population Health, Sachin Chinwar, Data Science Manager, and then from the NC Health Information Exchange Authority, we have Kenya Servia, Business Development Outreach Specialist, Tim Taylor, our Application System Specialist covering NC Notify, Kim Webster, Business Development Outreach Specialist. She'll be handling our question and answer box in the WebEx meeting, and then myself, Garrett Smith, Business Relations Manager. So just to kind of give you a background on some updates from NC HealthConnex. So here is a link to our monthly update. So once you get the slide deck, you can click on that monthly update and get information on some of the recent updates. But just as a high level, the next HIEA Advisory Board meeting occurs Thursday, September 15th from 2 to 5. You can click that link for the registration details. Here's some important legal updates as of July 2022, just this past month. So the enforcement mechanism is temporarily suspended until a bill that designates a lead agency responsible for enforcement of the Statewide Health Information Act is enabled into law. So until we have direction on an agency that will be responsible for enforcement, that has been suspended. The connection deadline of January 1st, 2023 still remains. Historically, we have seen that if we push that date out, the providers don't have an incentive to connect, so we lose engagement. So that's why that date has remained. And then in March 2023, the General Assembly received a report from us, similar to the report we did in March of 2022, outlining the status of who's connected and who's not connected by the January 1st, 2023 connection deadline. So now I'm going to hand it over to Kelly Crosby with NC Medicaid to cover an overview of Taylor Care Management.
Hi, everyone. And Garrett, thanks so much for having us today. And as Garrett said, I'm joined by Lowell Alvarez and Sachin Chinwar from our team to help with questions. But today we're talking about a very specific component of tailored care management. And what I'm here to talk about is a bit about what the technical requirement is, but even more so the why. And then I will turn things over to our colleagues at the HIE, which is our publicly available source of this information that I'm going to talk about today. So again, tailored care management, you've probably heard me, our team, present on many components of tailored care management, including this one, but I'm going to do it again today. So next slide. So the first thing I just want to remind folks of, if you go to the next slide, is where we have published the different requirements around the data that is required for tailored care management. It is a very data-heavy service for a reason. All of the data that we have that is exchanged between the department and plans and between tailored plans and providers and back again is because we think that information is incredibly valuable. It's information that we have, that you have, that plans have, that tells us something about what's happening with the member. So we want to share it. So really at the end of the day, so tailored care managers can be most effective. Today we're talking about a very specific data source, but here's documentation. We've got FAQs out there. The manual talks about the data requirements, and then we spend a lot of time standardizing really specific data in the care management data system guidance. So there's a website devoted to that. Go to the next slide. I'm just going to do a quick high-level overview of kind of like this, some buckets of the data requirements. We've done these in other presentations, but I just want to remind folks. Just to get in the gate to be a care management agency or an advanced medical home plus, you've got to have an EHR. It's just kind of like a check. You do that, so you need one, period. To do care management, you also need a care management documentation system. It doesn't have to talk to your EHR. Wouldn't it be nice if it did, but it's not required. So all of your care management documentation can sit right there in your care management data system, your care plans, your assessments, the notes you take. It can all just sit in your care management data system. It doesn't have to connect to your EHR, and we don't need duplicative documentation. We get a lot of questions about that. We also very much want our care managers to use NC Care 360. Some folks are connected already, some aren't, some are in process. Everyone's trying to connect their NC Care 360, so sometimes they have a really big waiting list. So once it is operational and available everywhere statewide, we will require our tailored care management agencies to use it, but in the interim, we're encouraging you to please connect and use NC Care 360. Now, a tailored care management provider can do any of these things themselves, or fulfill these data requirements themselves, or they can work with as part of a clinically integrated network who uses a shared resource, for example, or a provider just might contract with their own technology vendor. So for example, majority of providers contract with some technology vendor to purchase their EHR. Great, great, done. Some other providers might join a group of providers. We call those clinically integrated networks. It's not an official term, but it's a group of providers that go together on shared resources. So many of our providers are joining other groups of providers, and they're using a shared care management platform. It makes a lot of sense. You got one platform, you got one technology vendor you're all buying into, you got economies of scale, and that care management technology vendor that the CIN is using can ingest all the data, do analytics, host the platform for you, do all the data exchange. That's great. Some providers are just doing this themselves, and they're contracting with their own technology partner, whatever it is, ABC Care Management Technologies, and they're purchasing a care management platform and analytics and all that data warehousing from a technology provider. It's all good. However providers make do, we want to support that. That is great. So on the next slide, the other thing that we talk about in those data documents that we showed you at the beginning of the slides is the other types of information that sometimes we share with the plans who share it with practices, sometimes the plans share it directly with practices, and the data that comes back from CMAs and AMH pluses. All of the data, for the most part, has been standardized. So we send member assignment data. So all care management agencies will get their assigned member list. So it'll be their assigned members with all the demographic data we have. So we'll have race, ethnicity, gender, identity data, primary language data, but we'll also have the member's address and contact information, if we have their phone number, if we have their email address. And it will share guardian information if the member is a minor. So that's just all the demographic information that Medicaid has. We have a specific format that we use to send it to plans, and they will use that format to send it to you, and all those formats are published. We will also send, to the tailored plans, and sometimes the tailored plans produce this themselves, all claims and encounter data. So think about how valuable that is if you're a care manager. Your member might not be able to tell you, oh yes, I'm on these medications, and oh yes, I went to this specialist. but that claims and encounter data it can tell you. So you can see those things and you can use that for so many reasons, mostly just to provide better coordinated care. But again, standardized format that plans will use to share that data with AMH Plus's CMAs. We also have a standardized format for sharing acuity tiering and risk stratification data. So all members will have an acuity tier. So there'll be high, medium, or low behavioral health or ADD. And there's a specific report. It's called the PRL, and you will get that acuity tier information and other information in the member on that. And in the future, and if tailored plans also add additional risk stratification to that, they can use that. Tailored plans will also send quality measure data to you once we define a quality measure set. There is no standardized format for that. But we are talking with the field now about the potential of that. But it is lower on our priority list, to be perfectly honest with you, because there aren't any specific quality measures yet. Optional data is really, the plan might have other data that they would like to share with you. Maybe they were the care manager beforehand. They have old care plans. They have old assessments. They would like to share that information with you. Tailored plan to provider. That's wonderful. So in other cases, they might want to send data down to practices. We don't standardize those things. They could send them through secure SFPT sites that, whatever, because those aren't required other things that they share. Back, practices will send care management data. There's a standardized report. Again, it's that report called the PRL. On the PRL, we'll get all the contacts and key interventions for a member. It is standardized for a reason. So practices fill out one type of report, and that report goes to tailored plans who consolidate it and send it on to us. So we're trying to make sure the data that goes to practices is quite standardized, and the data that comes back is any standardized format. So providers are doing one type of format. It's still a lot of data exchange. It's extraordinary, which is why, of course, most providers are choosing to either join other providers and use a technology vendor or just using a technology vendor to help with all this. So again, none of this is ADT, by the way, none of it. It's just an opportunity to go through the data one more time. All right, next slide. We're going to get to the ADT, I promise. So here we go. So we just talked about that first box, all the clinical all the claims and encounter data, the member demographic data. We're doing really cool things with standard plans, which this is not about yet, to share clinical data now. But the real thing we're going to talk about today is that ADT information. So that's why there's a big star. ADT information. If you're a tailored care management provider, you are required to have a source of ADT information, which is why we're here today with the HIE, because they are an available public source here in North Carolina of admission, discharge, and transfer information. So why does any of that matter? That's what I want to talk to you about. So next slide, why does it matter? What do we expect you to do with that data? Primarily, we expect you to do something called transitional care management. If you go to the next slide, you want to do fancy things with that data, right? You're going to do risk stratification and all kind of thing to help you find the members you should focus on the most. But really, we want you to use it very real time. ADT is real time. You can get it every day. Sometimes you can get it multiple times a day, depending on the kind of connection you have. Tailored care management is responsible to help members during transition. Why? Because transitions are a time of particular vulnerability. Individuals who are in the emergency department, individuals who are hospitalized and coming to home, individuals who are leaving a residential treatment facility. We're in a short-term nursing stay for rehabilitation and going back to the community. Transitions are complex. We've known this for well over a decade now, and care management has focused on transitions forever. They are a time of incredible vulnerability for members. It's very hard to come back and reconnect to the community. So we require, per the tailored care management policy, that tailored care managers support clinical and residential transitions. So I highlighted everything in red that the ADT is going to help you with. Transitioning out of a hospital, so going from inpatient or emergency department to the community. As I mentioned, transitioning out of a residential setting between clinical settings, but also life transitions. So if a member is transitioning out of school, a member might be transitioning from a pediatric practice to an adult practice. A person might be going from one job to another or may just have lost their employment. So there's a lot of changes. And we say that's a pivotal moment for care management. But today, the real priority is just talking about the ADT information and how that's such a critical important data source that is available and it is required because we want folks to really pay attention to those transitions from emergency department and inpatient to home. So on the next slide. So again, the manual itself says you should provide care management during these moments. We call it transitional care management. You should also reassess the member's needs. You should update the care plan if needed. And these are a list of required reasons that you would have to update the assessment or care plan. So once again, top 2 reasons that really factor in are if someone has been hospitalized or they've had at least 2 ED visits. So first slide was, please monitor all transitions. And you've got to think about trying to help members in all those transition points. Here, we're also saying, besides just doing care management, if someone has been hospitalized or went to the emergency room for some sort of crisis, please reassess. Is there something else or different that a member needs to make sure they get safely back in the community? Do they have a new goal? Do they have a new need? Do they need a new referral? To make sure they stabilize in the community and don't end up right back in, right? Okay, next slide. Transitional care management functions are explained in the policy. So there's just a lot of things a care manager should do. Those are all laid out here. So everything from a care manager is assigned to the person already. They should do outreach to the member, to their other providers. A really key area, number 3, that I do want to talk about is assist the member in obtaining medications. I stress this one in particular because that is a particular place of vulnerability that we found with folks coming out of inpatient and ED. There's also been a lot of emphasis from hospitals on making sure they coordinate with the members' external or ambulatory providers to say, I'd like to change the med. Or I think part of the reason the member came is because the meds weren't quite right or they had 2 conflicting meds. So there's a lot of effort to make sure physicians are coordinating, prescribers are coordinating, but that's something the care manager really needs to help with, to make sure that the providers have coordinated, that the member understands the member changes. And a big thing that often happens too, sometimes members' prescriptions will get sent to the wrong pharmacy. So making sure that your members actually know how and where to pick up their medications or to change them to a different pharmacy so they go to the other pharmacy that they're used to going to. So medication is a real crucial area that I just want to point out. And there's a lot of other important things here too, but I think transportation and housing are often 2 other really big needs too. So making sure like medically folks are okay, but also there are things that potentially precipitated the crisis or could help the patient or could be challenges to the patient. Unstable housing might be part of why they got there, or living arrangement, something that precipitated the crisis, or an extenuating life change or circumstance, loss of a job or loss of housing or loss of a relationship. So that might be the situation a person's going right back to. So we need the care manager to think about those scenarios too. Okay, next slide. Trying to leave lots of time for my colleagues. Okay, so this is just makes the point again that that information is very real time. The expectation is absolutely that providers are looking at that ADT information at least once a day, maybe more times a day, and you're acting upon it. You're reaching out to the member, sometimes when they're still inpatient. You're reaching out to the member, sometimes when they're sitting there in the ED, and you're helping them, and they're talking to the discharge planner and figuring out how they are coming back. But that's why the information is so key. This is not claims data that's 3 months old. This is real-time information. Person sitting in an ED, they're waiting to be transferred. They were just transferred. They're sitting inpatient, and they're going to get discharged in the next 24 hours. What can you do in those critical moments to help them? Say, I'm here, I'll help. Let's figure out your aftercare plan with your discharge plan, your providers. So those are really critical moments. Okay, and there's very specific criteria here. Again, it's in the manual, specific timelines and criteria. Next slide. So we just want to wrap up with just two scenarios, right? So we've got a member, and we described the member. Fairly typical, could be any of us, right? It's an individual with low income. They're on Medicaid. They have a history of opioid use disorder. They're not in MAT. They are actively in treatment. They're actively in recovery. But there's potential in this member for relapse. You know that from after working with this member. Now, this member was involved in a car crash. and they went to the emergency room, they had a fracture, they didn't need to be admitted, and they're discharged potentially with some medications. So this individual, you get an alert, they're in the emergency room for being in an accident, and we want the care manager to see that alert and do something about it. So if you look on the next slide, we tried to track how the data might move, right? So this member is working with an AMH Plus practice, and that practice does the care management. They have in-house care management staff, but they've got a CIN, and their CIN is the one that does all the data from them. So they get all that data I mentioned from the tailored plan, but they also are the ones that are getting that ADT alert, right? They're getting that, the CIN, their technology partner's getting that. So let's look on the next slide about how we think things should work. So if you look at step one, way on the right side, so the individual went to the emergency room, okay? That shows up in an ADT report, same day, okay? 2, that ADT alert should be picked up by whoever is responsible for picking that up. If it's the provider directly, because they get the defeats directly from the HIE or other ADT source, or it's going to the CIN. Goes to the CIN, that's fine. The CIN should absolutely have a way daily and in a time-sensitive fashion, maybe multiple times a day, send that ADT alert to the practice where the care manager is sitting. And then the care manager just does good work. They reach out to the member. They reassess the needs. They talk about other plans. They make sure meds are okay. They check in with their PSYOP provider and make sure that they're stable. Any other needs? Maybe the member doesn't have transportation now because they were in a car accident. What is it? So the care manager is just going to do really good care management. But all of that was triggered by getting good data. You might not have found out that that member had an accident until the next time you connected with them in 2 weeks because you were doing a routine follow-up. Maybe they called you 3 days later, but the ADT information says, hey, you don't know, but your member in care management was in a car accident. Reach out, find out what you need to do to help this member transition and be okay. Second scenario, I think that's my last thing. So scenario 2. So this is a member in a tailored plan. They've got a care management agency. So the individual has bipolar disorder, has used lithium for a long time, and also has kidney disease. So unfortunately, this member ends up getting hospitalized because uremia. So there's some kidney dysfunction there. They've got low blood pressure, and it of course is affecting their mental status. Of course it is. Kidney function affects mental status, disorientation, mental health, and we're all thinking about people in holistic ways, right? The member is sent to a nursing facility for short-term rehab. This is not a long-term stay, but they might go to rehab for 2 to 4 to 6 weeks, depending on what they need, to make sure that they are stable, that their meds are okay, that any disorientation or other mental issues resolve, and the facility says this individual needs dialysis now. So there's a lot that happened there in that inpatient stay. So let's track the data again. So the member is admitted into inpatient. The hospital sends the ADT feed to the HIE. Garrett will tell you how many times a day it is. In this case, too, the care management agency is using a technology vendor. That technology vendor is ingesting that data every time it's going through the HIE, and they alert the care management agency. So the care management agency reaches out to the member, reaches out to the facility that they're in, and helps the member get restabilized in the community. And it might be a lot. They're gonna need to follow up with their psychiatrist about their medications, with their primary care doc, setting up dialysis. What a life change, right? And we know in these situations, the skilled nursing facility, the hospital's gonna do a good job. They're gonna make all the right aftercare referrals. And sometimes the care manager's job is just to make sure you do a reassessment with a member and say, do you understand what happened? Do you understand all the referrals that have been made for you? Can you get to these appointments or not? How can I help you? Make sure that all of these new referrals and these new life changes that are now part of your life, make sure that you're able to adjust to those changes and thrive again back in the community, right? Okay, and I think that is probably my last scenario. But I think overall it's just trying to make the case that it's not just data for data's sake, because we want to make a really hard requirement. Many care managers will tell you that ADT is one of the most important data sources that they have, next to talking to the member, right? Because what's more important than that? but being able to get this very real-time actionable data at key moments in a member's life so you can make a real difference in kind of crisis and other really big changes in the member's life is just really, really important. And so now we're very excited to be co-presenting here with HIE today. This wonderful team of Kenya and Timothy, Garrett will tell you, and Kim will tell you about this wonderful source that many of you already know about. And I will turn it over to the experts. So thanks, Kenya.
Thank you, Kelly. Next slide, Garrett. So the vision for integrated care or whole person care is that effective, integrated, and well-coordinated care management depends on care team members having the ability to efficiently exchange member or patient health information and use that information to monitor and respond to medical and non-medical issues that could impact beneficiaries. So how can use of a health information exchange, specifically NC HealthConnex, support this vision? So first we want to explain to you and level set what a health information exchange is. A health information exchange is a secure electronic network that gives only those providers that have an authorized relationship the ability to access and share health-related information across a statewide information highway. It's important to note that only providers with full participation agreements have the ability to utilize our suite of services that we're going to review today. So if you imagine NC HealthConnex sitting behind your EHR, extrapolating certain data elements from the different EHRs that it's connected with and having that information on display for the providers, again, that have full participation agreements. Next slide. So who are we? In 2015, the North Carolina General Assembly created the North Carolina Health Information Exchange Authority in order to help facilitate and modernize the state health information exchange, which is known as NC HealthConnex. The Health Information Exchange Authority is housed within the Department of Information Technology's Government Data Analytics Center. We partner closely with SAS Institute in a public-private partnership, and they are an analytics company that works closely with the electronic health records vendors of the providers that have signed participation agreements with us in order to stand up connections to the Health Information Exchange. And with regards to governance, we do have a 12-member advisory board that is made up of healthcare representatives, including the Department of Health and Human Services Secretary and the Secretary of the Government Data Analytics Center. The Department of Information Technology and the GDAC Director. So we connect healthcare providers in order to safely and securely share health information through a trusted network in order to improve healthcare quality and outcomes for all North Carolinians. To date, we have over 60,000 providers that are contributing records to our health information exchange, and we have over 3,000 behavioral health providers that are participating. We've connected with over 8,000 healthcare facilities, which includes 140 hospitals in our state. In addition to that, we have an onboarding queue of over 5,000. That consists of providers that have completed a participation agreement, but they're not yet live and submitting their data. We've also received to date over 150 million continuity of care documents from 11 million unique patient records with clinical documents. We're live with over 80 EHRs, and via our border and interstate connections, we've stood up over 22 connections, which includes our connections to the Veterans Administration as well as the Department of Defense. Next slide. So what are the benefits of health information exchange? It allows you the ability to see a full picture of your person's health, including medication history. You can provide real-time notifications of important health events. Providers receive efficient medication reconciliation to help reduce errors and unnecessary testing. It also allows for increased access to patient information to help close gaps and improve outcomes, as well as reduce phone calls and faxes. Next slide, please. So first, I want to go over the unidirectional connection as we're discussing our exchange capabilities and how a health information exchange works. Providers with either full or submission only participation agreements have the ability to submit data to the Health Information Exchange. However, only providers with full participation agreements have the ability to query or view the data that populates the Health Information Exchange. So the providers would enter that data directly within their EHR, whether it be medications, encounters, procedures, allergies, so forth and so on. And again, via any search engine with the exception of Internet Explorer, providers have the ability to query the Health Information Exchange if they have a full participation agreement. Now, the unidirectional connection is available to, again, providers either submission or full participation agreements, but only full participants have the ability to query the data. Now, next slide, Garrett. The bidirectional capability is only available to our providers with full participation agreements. A bidirectional connection involves data flowing in two directions, both to the Health Information Exchange from the participant and from the HIE to the participant. The graphic on this slide shows the flow of data. In this image, you see the flow of data from the EHR to the HIE. Once that data is entered or given on a given patient into the EHR, it is automatically sent to the HIE, and then providers who have bidirectional connections configured and are part of a care relationship with that patient, they then have the ability to access and query that data directly within their electronic health record. Next slide. So I've discussed our reach and exchange capabilities, including our clinical portal, the unidirectional connection, as well as the bidirectional connection. In addition to that, we do offer a direct secure messaging feature, which is a HIPAA compliant and convenient way that providers have the ability to share protected health information. This service is again available to providers with full participation agreements upon request. We've also stood up additional integrations to the controlled substance reporting system. We're connected via eHealth Exchange and the patient-centered data home network, and we're also working to connect via care quality. And I'll leave our NC Notify ADT notifications to my colleague Tim to review. Next slide, please. So with regard to eHealth Exchange, two connections that I'd like to bring your attention to are connections to Coastal Connect Health Information Exchange as well as Vidant Health in Greenville, North Carolina. The key thing to note about the eHealth Exchange connections is that they are query-based versus our connections to the patient-centered data home, which are push notifications that we receive at NC HealthConnex based on your home zip code. So those notifications are pushed back to us from the 43 health information exchanges across the nation that we're connected with via NC HealthConnex. And with that, that concludes my portion of the presentation, but I'd like to hand it over to my colleague, Tim.
Thank you so much, Kenya, and good afternoon to everyone that's on the call today. I'm delighted to be here with you and have this opportunity to come back and speak again on this Teletown Hall. As you know, my name is Tim Taylor. I am the lead analyst for NC Notify with NC HealthConnex. And so I thought that both Kelly and Kenya did a tremendous job of leading up to this point where we could start talking about the event notification service, NC Notify, and how you guys can receive those ADT notifications. Prior to joining the Department of Information Technology with the state, my background was in healthcare operations management, and I spent most of my time in outpatient settings. So I'm always excited to talk about NC Notify because I know the tremendous benefits that it can bring to your clinic and your organizations. So with that, we'll go ahead and jump right in and just really talk at a high level about what it is. So on this first slide here, we'll start over to the right-hand side. Much of the information at the top, Kelly has covered really thoroughly. This is the vehicle to help you guys receive those ADT messages. But just so you can kind of understand some of the stats, currently we have more than 600 live participants, which includes LMEs, MCOs, and behavioral health organizations. More than 8 million patients being monitored, and we're averaging nearly 2 million patients each month. I'm sorry, alerts being sent out each month. So again, going back, Kelly, during her presentation earlier, she walked you through two different scenarios, and so which is very similar to what you see here on the left-hand side of the screen. Now, I will put a pin right there and just say that with NC Notify, there are two tiers. We have the NC Notify version 4.5 base tier, and then we also have the plus tier. Now, which tier that's going to be the best for your organization really is decided, during your periods of onboarding and enrollment to the service. As that is one of the things that makes NC Notify unique, is that in order to participate with this service, you must have signed a full participation agreement with NC HealthConnex. And so once you sign a full participation agreement, at that point, you can begin to enroll to the NC Notify service. And I'll work very closely with you to help get that done and answer any questions you might have so that you can, select the best tier that's going to be the best fit for your organization. But since we have this slide here up on the screen, much like Kelly described, whether you choose to go with an independent connection where the ADTs are going directly to your organization, or if you're working with another organization, which we refer to as a third party, in either case, it's similar to what Kelly described, where the patient has an event and registers at that ED or has a hospitalization. That ADT message is going to be sent back either directly to you. And here on this particular graphic, that ADT message is represented by the X-ray. But it is going to be sent to you. If you choose the near real-time option, that option is available to you, both on the base and the plus tier. Again, it's really going to depend on what the best option is for you. And I'll go through some of those details in a second. But at the time that that patient is matched with your organization, down at NC HealthConnex, we will send that to the nurse in the bottom left-hand corner. That's really showing where we're going to send you that alert back immediately. As soon as we have that match made, we're going to send you that notification immediately. And just as an example, to give you an estimate of time, if that patient registers or has an event that takes place at 9 a.m., it's highly likely that your organization and your care team will know about it before 9:30. And the last step in that process there, it really goes to, that's the biggest benefit of this service, is that the follow-up planning can go ahead and begin. Next slide, please. All righty. So not to go back over what Kelly has said, but these first three bullet points here were taken directly from the DHHS website. Three of their areas of focus around tailored care management, which was community-based, provider-driven, and whole person care. And during my time now, a little more than 3 years of working with NC Notify, I really think we have some wonderful solutions to help bridge those gaps. The first of which being enhanced care coordination. I'll show you some examples and some screenshots in a couple of slides from this one, where I can show you how it really does help to enhance care coordination across your transitional care teams. Secondly, we have some new alerts and enhancements. And our efforts to do that and to continue to grow this service so that it can really work well for you guys out there in the field. That's an ongoing effort for us. And I actually have a slide that shows you some of our most recent enhancements and how they can be a great fit for you all. And lastly, this is one that we've received more than a few times from organizations that are currently using NC Notify. They use this service as a way to confirm referrals, to make sure that once referrals are written, that patients are actually going to those referred appointments. Next slide, please. All right, so how does this all work? So just taking a step back, and when I first started, I was talking about, the organization must first have a full or sign a full participation agreement. And then from that point, we actually have a web-based enrollment form. It's a really convenient way where an organization can quickly enroll to the service. It's far more efficient than some of the ways we had in the past. And I actually have screenshots that I'll show you later on that. But let's just fast forward. Let's say that your organization has already signed the full agreement. They've already successfully enrolled to the service. At that point, we refer to them as subscribers to NC Notify. And so basically, the question that I get early on oftentimes is, well, Tim, with my organization, how will you all know? How will the NC Notify team know who we need you to monitor for us? And there's a couple of ways that that can be done, but in short, we need a list of your patients, and we often refer to that as a patient panel or a member roster, and that's something that your organization will provide to us. Now, again, let me pause here just to say, I mentioned that there's a couple of ways that that can be done. About a year and a half ago, we released a feature called auto attribution. Now, in order for your organization to use auto attribution, you must not only have signed a full participation agreement, but you must be connected and sending data to NC HealthConnex. So your connection must be live to utilize this feature. Now, the benefit to the feature, and the reason I bring it up here, is as I mentioned patient panels, auto attribution will build that patient panel for you automatically and continue to maintain it on an ongoing basis. Now, let's just say that, okay, Tim, well, my organization has signed the full agreement, but we're not yet live. We're still going through the connections process. That's not a problem. You still can use NC Notify as a full participant. The only difference being you won't be able to use auto attribution right away. It will require you to build a patient panel, and we have specifications depending on the tier that you choose, whether you go with the base tier or the plus tier. We do have a specification document that I could provide you the link for that. It's also on the website, but that will give you very specific instructions on how to go about building that patient panel and then submitting that to us. And again, that patient panel or member roster just lets us know who you would like for us to monitor for you. Now, at the time that we have that, we will then monitor that panel for you. And let's just say that I'll use the same example that Kelly used earlier. The patient was in a car accident. That patient's in a car accident and is registered at that ED. At the time of that registration, that organization is also sending data to NC HealthConnex. Now, once that hits NC HealthConnex and the match is made, and when I say match, I'm referring to the member from the car accident is matched, is the same member that's on your patient panel that you submitted to us. We're going to push that back to you immediately so that your team can go ahead and take action. Now we're on the third farthest right side of this slide, and it's kind of getting more into detail around those two tiers that I was talking about. Because another question that's commonly asked is, well, Tim, if we're receiving the alerts, what will that look like on our end? What options are available to us? And so here, again, it goes back to the tier that you choose. On the base tier, you can, well, on base or plus tier, you can actually choose to receive batched files. You can receive batched files hourly, once a day, or if you want to receive more real-time notifications like I was describing on the base tier. Now, this one is specific to the base tier. You actually can utilize HL7 notifications. So that's going to give you access to the real-time. And then on the plus tier, there are a number of ways. I mentioned you could receive a batch flat file there, but then there are some other tools that are very popular amongst some of our providers as well. So with that, if we can go ahead and transition to the next slide, just want to talk about some use cases here so you can kind of get to see some of the feedback that we received from our participants. So first, and I'll just kind of skim through these to hit the highlighted areas. So with this one, with services like NC Notify, the entire team can have much needed information to keep patients safe, during the riskiest times. That probably should have been highlighted as well, because that's a key point, keeping your patient safe during the riskiest of times. But here's the T portion of the ADT part, when they transition between one care entity and another. And again, I think Kelly did a wonderful job describing the importance of being notified during transitions. Secondly here, this one, and I'll paraphrase, what I really like about this particular use case is that this really helps to identify the gaps that can be in communication, oftentimes between one facility to another, or from one patient to the facility, or even to your care team. If you notice there in bold, in this particular case, this provider saw the event happen. They received the ADT. They wanted more clinical details, so they then went to the NC HealthConnex portal and pulled the CCD, the more longitudinal record with far more clinical details. And from pairing those two tools together, they were able to learn information that the Guardian, that you see here in bold, failed to let them know. So that's another great benefit there. And then lastly, we'll just focus here on the bold piece. And you can go back and take a look at these, but for the sake of time, I want to make sure that we have time to, I can walk you through what some of these tools look like. But here in bold, this is our real-time data gathering from the HIE has allowed us to prepare for a remodel of our system to asynchronous, real-time, knowledge-based care. And so with that, let's go ahead and transition to the next one. Garrett, I really want to spend some good time here. Now, the next couple of slides that you're going to see are specific to the plus tier. I mentioned the base tier. This is the plus tier. And this tier has been probably more popular with our behavioral health community, but just want to kind of walk you through information that you can receive that's really kind of over and above just the standard ADT type of information. Earlier, I told you I was going to share with you some of our most recent enhancements, and that's what you see here on screen. Two of these in particular, well, there's one of these enhancements I'm going to point out in particular because during Kelly's presentation, I believe it was around slide 13, she had them bolded and in red, where she talked about hospitalizations and 2 or more ED visits since their last assessment, I'll just say. But I'll talk more about that one in a second. But first, we've talked about the ADTs already. This is another one of the new alerts, COVID-19 alerts. So this will let you know, it will send you an alert whenever one of your patients or members has a COVID test, and it'll send you the results, whether positive or negative. High utilizer alert. This is the one that goes back to Kelly's slide. And the reason I wanted to point this out here is because this slide, well, this particular alert will alert you for both hospital readmissions, also high ED use. So if a notification of at least 2 ED visits within 90 days or 4 inpatient admissions within 12 months. That particular alert is very popular among all of our plus tier users. Dental alerts. If you have a patient that goes to the ED for anything dental related, you'll get an alert for that. So your care team can make the necessary referrals if need be. Care team change alert. This is also another plus feature, a new enhancement. And basically what this alert is going to do, this is going to alert your team, your care team, anytime there's another health facility across town or somewhere that, you remember I mentioned the patient panel? If there's another healthcare facility or organization that submits a panel to NC Notify and it has one of your patients on their panel, your team will get an alert just letting you know that there's a new care team that's also monitoring your patient. And lastly, the diabetes alerts. If you have a patient with a patient with a new diagnosis, and this is, of course, this is based around diagnosis code. But if the system recognizes a code for a patient that's a new diabetic or maybe a pre-diabetic diagnosis, it's going to alert you so that your care team can take action immediately. And then lastly, this is for providers receive an alert when a patient meets the Centers for Medicare and Medicaid Services Chronic Care Management services criteria. Again, all of these alerts are the new enhancements on the plus tier. And if Garrett, we can go ahead and transition to the next slide. All righty. This is probably the single most popular feature on the plus tier. This is what we refer to as our NC Notified dashboard. Now, I'm just going to take a step back to something Kelly mentioned, and I mentioned it also, and that is whether your organization decides to connect with us, enroll to notify, and have either an independent connection or a third-party connection. Or you can do both. If you choose to have an independent connection, though, this is one of the options that's available to you, and one of the options where you can view your notifications in this way. So before I walk you around the screen here to see what we're really looking at and its functionality, this NC Notified dashboard lives on the NC HealthConnex portal. So if you don't already have credentials to log into that portal, that's one of the questions that's on the web-based enrollment form. And we've really streamlined the process so that if you check the box and says, I don't yet have access to the portal, that immediately alerts our help desk and they'll reach out to you and help you get that access that you need. Now, once you get access to the portal and you log into the portal, you'll notice across the top, the tabs, there's an NC Notify tab at the top. When you hover that tab and you click View Notifications, once this feature has been turned on for you, it will bring you directly to your dashboard. Now, how is this dashboard populated? It goes back to that patient panel that I mentioned earlier. Whether you send us a panel manually, we'll begin tracking your patients, and as events take place, they will populate over here to the left-hand side of the screen in near real time as they're happening. If you use auto attribution, the same concept, whether your panel is being built automatically or being sent manually, it is being monitored on the back end. So again, as events happen in near real time, the alerts will populate to the left-hand side of the screen. So let's use Ernie, the first patient there at the top left. While we're here, I'll just mention, of course, all of this is fake patient information. But using Ernie's chart, as I hurry, you can see at a quick glance, it'll tell you where Ernie went, time and date of the event, and the type of event that it was. So that's really beneficial for care teams to be able to spring into action as needed. Now, when you click that chart over to the right-hand side of the screen, you can see far more detailed information, and some of those, all the enhanced alerts I mentioned on the previous slide, this is where that type of information will populate. Next slide, please. Now, I just took a quick screenshot here so you'll know what to expect if after this presentation you choose to go out to our website and enroll. If you go to the NC Notify tab and look on the right-hand side of the screen, you will find online enrollment form, which you can see here. And this is just a screenshot. It's all online. There is a PDF option if you choose, but this option is far more efficient. You can do it all on screen, and when you click submit, you'll get a confirmation and it'll come to my desk, and we'll return the signed copy to you, and we'll move forward with onboarding from there. And again, I'm always available to help if you have any questions about which tier is going to be the best option for you. And let's go ahead and transition to my last slide, Garrett. And this is basically just a compilation of very important links or links that will help you to access much of what I described here during this presentation today. And so with that, I'll just thank you all again. Thank you to my esteemed colleagues. It's great to speak with you all again. And from there, I'll pass it back to you, Garrett. Thanks again.
Thanks, Tim. Thanks, Kenya and Kelly from the Medicaid team. Just going to wrap things up. We have about 3 or 5 minutes left. So just want to go through a couple of recent questions that we've received that might be helpful to understand the answer to. So first question, if I am an IDD provider, am I still required to connect to the NCHIE? And I'm sending these slides out so you have this reference, but per this statute, the intellectual and developmental disability services support providers such as day supports and supported living providers, are considered volunteer and not required to connect. So you can look at that that statute. It has, I believe, 10 different providers that were made voluntary. The next question, can a participant enroll and utilize NC Notify without completing a connection project with their EHR, their electronic health record system? The answer is yes, and Tim just went through the two different sort of the methods of receiving a panel. So a participant can can sign up with a full participation agreement, not be connected, but still utilize NC Notify without that connection. So if you're interested in that, you can just reach out. I have the contact information at the end of this slide deck. Next, the third question that we've been getting is, if my organization has a full participation agreement, what do I need to do to enroll to start using NC Notify? So in addition to the participation agreement, you would fill out the enrollment form that Tim just mentioned. The link is here. This contains the online form that Tim had gone through in his slides. So that's a resource for you if you want to get started, if you have a full participation agreement in place. So I'm just going to wrap up and give you a sort of the high level, what is the value of NC HealthConnex to providers? And I have 4 different dimensions here. So 4 dimensions are increase, reduce, improve, and integrate. So increasing operational efficiencies through eliminating phone calls and faxing, reducing duplicative tests and procedures, improving care coordination through NC Notify, utilizing those near real-time notifications, and then integrating with public health registries such as the Controlled Substance Reporting System, CSRS, COVID Vaccine Management System, Diabetes Registry, Electronic Laboratory Reporting System. So with that, I just wanted to leave everyone. It looks like we have about 2 minutes left. Here's the contact information for both of our teams. So the Medicaid team, the link to the Tailored Care Management site, as well as a dedicated inbox for Tailored Care Management inquiries. So that's there on the left. On the right, we have the website for NC HealthConnex, our number, and our email address. So feel free to reach out anytime with questions following up on this presentation. There was a couple of questions that I'll just go through a few since we only have about a minute. There was a question, will the slides be sent out? Yes, the slides will be sent out. I'll also include the link to the video recording of this presentation. There was a question, are notifications available through HL7 delimited file or only available from the portal? There are 2 options for that, and the methods, so the HL7, and I can let Tim go into this briefly if you'd like.
Yeah, you can. So, thank you for the question, and thank you, Garrett. And yes, you can choose either or. If the need for both is there, we can certainly explore that as well. But the HL7 notifications, you can get those in near real time or the batch files as well.
Okay, it looks like we've answered most questions. If there are follow-up questions, feel free to reach out to the email addresses here. We do appreciate your time, and we appreciate the partnership with NC Medicaid to host this presentation today. We hope everyone has found this informative.